Good day, everyone. Thank you for attending today's educational session. My name is Ron Alasco from International Trade Council. Before we start, I just want to make a quick housekeeping. If anyone from the audience can hear me, kindly please type in yes on the chat box, and if you can also see the PowerPoint presentation. Thank you. All right, perfect. Thank you. So our topic for today's educational session is healthcare for everyone, how digital clinics are changing the game. Our esteemed speaker is Chandramouli Samatam, founder and CEO of Care Health Tech Services. Today's focus in Phygital Clinic for Healthcare Equity, we're breaking down barriers by leveraging telemedicine to connect specialists with underserved areas. This physical clinics seamlessly integrate virtual and in-person care, empowering local communities and leveling the healthcare playfield. By optimizing resources, digital clinics make healthcare more affordable for all. Join us as we explore success stories, demystify technology, and shape a future where distance no longer limits access to health. Now, let's hear directly from our esteemed speaker who will be elaborating the topic. Please join me in welcoming Chandamoli Samatam. Go ahead, sir.
Yeah, thank you, Ron, for that introduction. Really appreciate. And good afternoon, good morning, good evening, everyone. I hope everybody is doing great. So before we get into the topic, I just wanted to emphasize on the phygital, the term itself. Basically, it means physical as well as digital, right? It's a blend of both physical as well as digital. So that's the reason that term has been framed by Phygital. So here is a quick agenda for today. I'll just quickly give you my background, and then we will highlight some of the chronic healthcare challenges in India. But I believe it's also relevant to in any other developing countries across the globe. Then we will also look at some of the deep-rooted problems and how government is actually intervening in those issues. What are the periodic solutions we have in right now? What is that we are talking about? The continuous solution. What are the benefits? Then I'll share some of the success stories we have, and what kind of market opportunity is there for this particular model, or I would say solution, and how to build a sustainable model around this initiative. And finally, we'll touch upon the digital inclusion, right? So how do we bring in the digital concept also into this? And at the end, I will also take some of your questions. So I will try and keep it probably 35 to 40 minutes approximately, so that we have more time in interacting and understanding this whole model and how it can be made operational on the field, right? So, if I go quickly on the introduction, so my name is Chandramuli, as Ron introduced me. I'm the founder of Care Health Tech Services. It's been over 2 years. We've been trying to address the healthcare needs of the rural communities, I would say marginal communities. I come from a background of business administration and also education technology. Uh, I think COVID has been the driver to kind of bring me into this healthcare field. Otherwise, indirectly, I was involved in the healthcare through my, I would say, my in-laws, my cousins, everybody. Most of them are in the healthcare field. So I was indirectly involved, but not directly. But I think COVID has been a major driver, which kind of helped me, kind of pushed me to get into this field. I have learned a lot, and my major inspiration is also my father-in-law, who served in a very small town in a very remote area for almost 40 years, right? And you can actually scan the QR code if you want to connect with me on LinkedIn, right? And with that, let me jump into the first topic is chronic healthcare challenges. So, my focus today is primarily targeting the rural areas, or I would say rural, tribal, or marginalized communities. So, that's where we are trying to focus on, because that is where the healthcare system is not so great, right? And also urban poor to some extent. So now coming to this particular problem, right? Like in this case, if you can see the picture speaks a lot. As you can see, he's a small child. Unfortunately, many of these children in the rural areas do not have access to a specialist doctor, right? I mean, they don't get to see a specialist doctor like a gynecologist or a pediatrician or a cardiologist or a nephrologist or a neurologist, right? So they don't have access to such doctors. And because of that major issue, I think a lot of these patients end up in serious situations like this, which is very unfortunate at the current times. So, as you know, in India itself, like nearly 68% of the population lives in rural areas, and most of the inventions, discoveries, whatever you call, in the medical technology or the healthcare technology, everything works for the urban I would say urban communities only, right? So most of the advanced technologies as well, they cater to the urban areas only. So how do we try and kind of bring balance, where we are seeing that many doctors are not willing to go to rural areas? I mean, obviously we cannot blame them, but majority of specialist doctors do not like to work in the rural environment. And for that matter, most of the doctors who qualify, once they graduate, they would prefer to work in a city environment, right? So that is unfortunately what the scenario is. As you can see the statistics as well, um, uh, in rural areas, again, zero point 0.7 doctors per thousand people, which is way below the who's I would say standard. And 60% of the healthcare of out of pocket is burden on the community members as well. So in India, if you say, nearly 60% of the rural population do not have insurance as well. So I think this is probably more or less similar in most of the developing countries. It may be worse or maybe slightly better, but otherwise I think it is a common issue across the globe. Now, I mean, this is one of the chronic issues we are talking about. Now, if you look at, again, deep rooted problems, right? I mean, we want to more emphasize more on the problems there in the rural areas, right? Now, again, 68%, as I said, which is close to almost 900 million people, they lack basic access to healthcare in these regions, and do not have health coverage. They have to spend out of their pocket. They almost travel to almost like close to 100 kilometers in in some occasions to visit a doctor, right? Imagine, if they want to see a specialist doctor, they have to travel almost like 100 kilometers, right? And professionals, again, shortage of professionals, right? Now, what government is doing, obviously most of you probably know, maybe in the other countries as well. So there is a government hierarchy system where we have sub centers, primary healthcare centers, and community healthcare centers. Now, community healthcare centers are the ones which needs to have the maximum capacity of, say, specialist doctors, or I would say at least 10 beds, right? And which basically caters to almost like 2.5 to 3 lakh population. But unfortunately, even those community health centers do not have doctors. 80% of those centers are obviously shortage of the specialists. And many of them right now, most of these rural population, they go to a quack. Probably you might understand, quack is somebody who is not who's not qualified enough to actually provide healthcare. So rural communities, because of lack of access, they end up going there, right? And the mortality rates, as you know, is very high in the rural areas again. Overall, I think the infrastructure also, if you look at, I think it's I think as per some of these statistics, I think 60% below the government standards, specifically in the primary health centers, 50% in the community health centers, right? And 70% of women rural India give birth at homes, because due to lack of maternity care, right? I think mother and child issues are the most prominent issues in the rural areas, right? So And so that's what really we want to emphasize. I think government in India as well as probably other governments across the globe are doing, but I think that's still not enough, right? So that's what I wanted to highlight. Now, so apart from the interventions by government, I think there are a lot of other activities which are done, right? For example, these medical units. So many of you understand these mobile medical units, which go in rural areas to different locations, enable, or I will say provide primary health checkups or primary care, right? But unfortunately, these are more of a periodic solution, right? It doesn't provide a continuous solution, because a medical unit might go to a particular village today, and then maybe access to that particular unit again may come only after a week, after a month. Again, it depends on the schedule and how many times these clinics are going to these locations. So at this current juncture, I believe medical healthcare is more of a continuous requirement. It cannot be a periodic requirement, right? Like it cannot be like once in a month, a kind of an activity. It has to be provided every minute, or I'd say every hour, right? So yeah, again, I mean, this is of course is one of the mechanism to enable care in these very distant locations. But again, what we are emphasizing here is these are more of a periodic facilities which has limitation to providing the amount of services, the kind of impact it can make, because on the day of their visit, probably there is nobody who's sick, right? And when the van is obviously moved out, maybe somebody got sick, right? So there is no way of enabling a continuous care with this model. Now, what we are trying to do, and the highlight of this topic, today's topic, is build a model which is a kind of a combination of both physical and digital, right? So this might look like a little overwhelming, but I will try and explain what we are trying to really do here, right? So obviously, on the left hand side, you see a telemedicine. Now, again, if you go back to the telemedicine, I think telemedicine has really done wonders during, I would say, post COVID or during COVID. And again, mostly the urban communities have been able to benefit out of it, because they had the technology access, I would say a mobile device or a tablet, and then they also had the knowledge, right? Like somebody from a city can connect to a doctor like a gynecologist or a cardiologist on their own, because they have technology and they have the knowledge to connect to a doctor on their own. Unfortunately, again, telemedicine has not done anything to the rural communities, primarily because many of them did not have access to smart devices like you and me, right? But even if they had a smart device, I don't think they were capable of connecting to a doctor on their own, right? I mean, you cannot imagine like a rural patient um, directly reaching out to a gynecologist, booking an appointment with her, and sharing her vitals or probably some details, and then doing a payment online, which is very unlikely or very remote, right? So main two reasons, again coming back, the telemedicine did not work in rural areas is because lack of access and lack of knowledge, right? Now, how do we ensure that the telemedicine is, or the digital aspect of this entire model is going to provide the quality care the people deserve in the communities, right? So that is where we try to bring in this entire concept of phygital, where what we are trying to do here in this picture, as you can see, we are facilitating that rural patient through this model, right? So the facilitator in this, it could be a health worker or it could be a primary doctor who's sitting in that particular in that clinic. He is the one who's going to facilitate the patient with the consultation. So he'll book an appointment, he or she can make an appointment with a senior doctor online, specifically upload vitals so that the specialist doctor has all the information which is needed, right? And then once the consultation is done, the doctor who's sitting in that primary care can still continue to manage them or actually handhold them, right? Because one of the biggest challenge why the telemedicine is not penetrating or not working in these rural areas is primarily because, as I said, of the technology and the knowledge, but again, the confidence of on that technology, right? Because a lot of people in the rural areas are mostly used to seeing a doctor in person, and they would not prefer to kind of get into a telemedicine call. So you cannot bring in drastic changes of introducing a technology enabled service immediately or instantly, right? So you have to bring them gradually, after a certain period. So I think this is the model where I think it fits into that requirement perfectly, where you have somebody locally who can guide the patient throughout the process of registration, taking their vitals, uploading their medical records, and then also participating in the consultation with the specialist doctor. So imagine there is a small clinic like this in a rural area, and there is a health worker. It could be either a doctor or it could be a nurse also, depending on the requirement. And that one person can enable quality healthcare with all these specialist doctors, like you talk about dermatologist, cardiologist, nephrologist, neurologist, and all these doctors can be enabled from that one center, right? Now, I think consultation is one piece, right? But I think the another major challenge in rural areas is the diagnostics. Now, I think that's where the technology is going to really make a big play. As you can see on some of the devices, I've just added them. Like some of these devices are something which we have introduced in our clinics. Not everything, but the idea of this digital clinic is what I want to kind of highlight. So, for example, there is this hematology analyzer, which is a very portable device from Abbott, which can be installed in this small clinic, and anybody who's like a health worker can probably uh, b- conduct a quick, say, blood test. So all kind of blood tests can be done, and typically what is required from a lab perspective, I think we can get those from that device. Then we have something called biochemistry. I think that also kind of helps in doing a lot of diagnostic set tests right at that center itself. Then we have portable devices like ultrasound, right? And again, these are very handy and mobile friendly. And imagine if these equipments, and again, point of care devices like rapid test kits which can instantly give you results, like for malaria, dengue, common disease areas in the rural areas. So you can use these kits so that you can instantly get results. So if the clinic is equipped in this way, where there is an assisted model where somebody from that clinic is guiding or helping the patient, and along with that they are able to bring in these devices which are very portable and which are easy to install. It doesn't require a lot of expertise or experience for anyone to handle them. I think with this model we can enable end-to-end healthcare to a patient who walks into this clinic, right? We're talking about mostly the primary care, right? And lot of, I would say, diagnosis like say cancer or any other chronic diseases. The screening can be really achievable through this model, where the patient can be immediately connected to a specialist doctor instead of waiting for several months before it becomes very serious, right? So this venue, I would say, this model really gives that a new way of enabling quality healthcare for patients to come in, right? Obviously it does not obviously become successful just by enabling these services. We probably have to bring in a lot of other network of say aggregators, or I would say companies like diagnostic services, maybe pharmacy, and screening, insurance, right? So, and also tie up with hospitals, right? So that once the patient is handled here in the primary care, and if there is some serious issues, then he can be transferred to the tertiary care, right? So I think it should be a kind of a, activity which has to be collaborated. But again, this model of enabling both the primary care, specialist care, and the diagnostics can be easily installed in a rural setup, right? I mean, with this model, because it doesn't involve a lot of investments. It doesn't also involve the doctors, I would say primarily the senior doctors, to travel to these locations. And similarly, the patient doesn't need to travel to these cities also for these advanced care, right? And the process is very simple. I mean, I just try to give you how this happens. Like, the patients, once they walk in, they do the registrations, and then their health records are created by testing their vitals, like their BP, sugar, and their temperature, and whatever vitals we need. Then once that is done, we conduct this consultation along with the doctor, then enable or create a digital prescription, and then do the patient follow up, right? So this will work exactly like a proper clinic in a urban area, right? It's the only difference is that we are not forcing the doctors to come to the region, right? So that's a quick background about this entire model of how we are enabling phygital clinics with these partner-led infrastructure, right? And now, if you look at the benefits, I think it has multiple benefits, because it, as I said, it can bring medical expertise to rural communities. Senior doctors, like say neurologists, can be enabled or can be provided through online consultations, and somebody locally in the clinic can offer the I would say support services from the ground, right? And diagnostics can be done timely, and the treatment can be given without any delay, right? So they can get the treatment instantly. And I think overall, I think it can bring in enhanced outcomes, because typically marginalized community, if they want to receive healthcare services, uh, they wait till the situation goes very severe. That's when they go and visit the city hospitals. By then, things have actually gone out of hand, right? But by enabling this quality services right at their doorstep, I think it can bring in quality health services, better outcomes, and also reduce the mortality rates, which are very high in the rural regions, right? Now, going on, so these are some of the, I would say, some examples on how we have been implementing this model in various regions. Like, these are some case studies. Like, this is on the top left hand corner. So this is a critical care patient, is a child, and she had a septic in her leg, and she need to be consulted with the senior doctor at a city based hospital. And I think this actually saved her, not only because it has come to a very critical stage. So they kind of been able to save her before they she gets into a critical situation, right? So at the right time, they were able to intervene and provide her a proper care. And then I think she was able to kind of come out of it very easily, without going into any complications, right? Now, on the right hand side, again, these are some of our implementations on how the technology can really can enable it. This one in the middle is the Africa, where we have been conducting some of these pilots. Again, the response has been tremendous. Again, here in these rural areas, for the doctor to go to these rural areas, they take almost like 4 hours. Wow. 2 hours to go, 2 hours to come back, right? So that's the kind of time they have to spend. Now, with this model, the health worker there on the ground is able to kind of again facilitate through the telemedicine, through this assistant model, and they are able to get this care right at their location. So neither doctor is moving nor the patient is moving out there from their locations, right? And again, these are some on the right hand side. Top right hand side is the camp, where again we do this regular camps and regular checkups. Similarly, on the bottom left hand side, we've also started introducing this model in some of the diagnostic centers and pharmacies, right? Even the pharmacies or the diagnostic centers, they can bring in these additional services into their model, so that the communities in the nearby surroundings or the localities can benefit out of this solution, right? So that is another way we can integrate it. And again, on the right hand side, uh, even if we don't have major infrastructure, right, like we don't need to have a proper clinic, so you can even set it up right at the middle of a area where you don't have necessary facilities. So as you can see on the bottom right corner, so where you can see again, a health worker is facilitating the call for a rural patient with this model, right? So I think the future is telemedicine, definitely. I mean, that is really what is going to make a lot of difference to the communities, but it has to be through an assisted model. So somebody has to assist the rural patient. I mean, if I have to make it very clear, like in today's scenario, in the telemedicine in urban model, if you want to connect to a doctor, every patient should have a device. So ideally, I will be able to book an appointment with the doctor and then get into a consultation, right? That's how simple it is. But again, in this model, uh, not everybody needs to have a medical device. So imagine a small village of say maybe 1,000 people, and if there is one person which is who's given this device and with some basic kits to do some examinations or diagnostics, so they can actually probably connect the entire community, all those 1,000 people, through this model. So where the need of the device, need of the knowledge or the technology is not required, and all the entire community can get access to quality healthcare, right? So I think that's where we really need to focus on. One is assisted model, but also bring in the physical model, right? Which is a phygital we are talking about now. I think globally it's a big opportunity. Right now, today, I'm trying to emphasize on India only. As I said, almost 68% of the population lives in India. And still, whatever government is doing, I don't think is sufficient. So even the private players should actually get in. And this is just a quick preview of the opportunity in India. But I think globally it is almost like maybe $500 billion opportunity, right? Because many countries like India are developing countries, and most of their rural communities are still have these huge healthcare gaps, right? So if you go anywhere across the globe, I think there is a need of a quality healthcare, mainly specialist healthcare, right? And I think this is a great opportunity for everyone, each of us, to kind of participate and see how we can bring a difference to these communities with this global opportunity, right? Now, now, so now the aspect now, right now, what we are trying to basically talk here is, I know there's a big opportunity, all right, but how do we make it a sustainable model? So here at Care, we built a very sustainable model. Maybe we can get into a very prolonged discussion on this. If anybody is interested, you can probably reach out to me. So the idea is, how do we enable quality services to these rural communities, and then also charge them very very low fees, right? Like it's not that you're enabling free of cost. What we are trying to say is, we charge them a very minimal amount. Like for example, in this case, uh, 60 rupees just is hardly probably less than $1, and then 150 rupees for a specialist consultation, we are talking about maybe $1.2, right, per consultation. So that's how. And people are in India, again, in rural areas, they are comfortable of paying that kind of expenses, because that is the kind of amount they pay to these quacks, who are basically not qualified enough to treat them, right? So what we have done is, we build a model where we will not I would say make their I mean they make them pay higher prices. Instead, bring to the same level as as what they are paying in the market right now. Because other than this, the other only alternative services for them is free service, or I would say through government institutions, or I would say it's health centers. Unfortunately, as I said, again, in those government centers, most of them, again, they have lack of access to these doctors and specialists and so on, right? So that way, if you see, the opportunity is there. Now, the way we have tried to do is build a model around this, and we have built a robust unit economics around it, on how this entire model is going to really become operational on the ground, by when this each and every clinic can actually become positive, and also probably get the return on their investment by probably 16th or 17th month of the implementation, right? And again, but it also has to bring in a lot of other aspects as well, because just the consultations will not really help the clinics to run effectively. You need to bring in other aspects of pharmacies. Either you tie up with somebody, or you have your own pharma center, right? Or somebody who's already is running a diagnostic center or a pharmacy, so they can bring in these model into their clinic, so that it becomes a win-win model for them. So the idea is try and look at getting some direct revenue sources, and also make revenue through other models like commissions, either supporting these patients, or selling devices, or I would say providing additional treatments, or even some of the other potential sources can be home visits. Again, this model has the capability of enabling home healthcare, right? Like, instead of patient coming to the clinic, a nurse can actually go to the rural patient's house. So ideally, let's assume the patient is unable to move from the house, and he cannot even come to the clinic. So the health worker can actually visit them, and then enable that service or the healthcare from there, maybe by connecting to a doctor right from the house of the patient, right? And that's how maybe those additional visits can make additional income, right? And nursing services, ambulance. So a lot of these I think models have to be integrated, but majorly on the top, it talks about these are some of the revenue sources, and these are some of the other indirect revenue sources which you need to look at to make the clinic self-sustainable, and it can run on its own, and also creates opportunities to the people from the within the community itself, right? So it has the ability to create opportunities for the local communities, and also serve the local communities with and provide quality healthcare by charging a very least amount of money, right? So I think that is what should be the aim of building a sustainable model, and we've already built that. We are implementing our model on the ground, and anyone is interested to understand more, so I'll happy to connect and respond, right? And moving on now, what is digital inclusion, right? So now, as you know, we are doing everything on the ground, with doctor creating appointment, and then uploading their records, vitals, and so on. So obviously they need to be assisted with some technology with them, right? So what we have built, a very simple and very easy to use platform for these health workers, either it is a primary doctor or a nurse out of this clinic. So they can easily create appointments for the patients within 3 steps, and book appointments with the specialist doctors. And then, so this is basically just a process flow of how the technology is going to work, right? This they can operate out of it, out of your tablet or your mobile phone, whichever is convenient for you, right, to use it, you can do that. And each and every health worker will have unique access, so that there is a record of who's actually facilitating the call for that patient, right? And we ensure that. And part of the process, as you can see, they can book appointments with the specialist doctor on specific times when they are available, then upload the medical records, or upload the symptoms of that patients. And once the details are shared, get into a call with the doctor, specialist doctor. And then once during the conversation, if the doctor suggests some tests, conduct those tests on the patient with whatever facilities or applicable diagnostic kits you have, and then share it back with the specialist doctors, and then finally get a prescription, right? So this is how seamless and simple it is to implement. We don't really need a high end, I would say, technology to really crack this model. I think the idea is to bring in the ease of access to people, both on the ground as well as the seniors, specialist doctors who are joining the call, right? Because end of the day, most of these senior specialists have very little time, and you cannot waste their time. So the focus is how do you limit their time on, probably limit their time mostly focused on patient interaction, or probably helping the patient rather than understanding all these details and documents, right? I think, see, the idea is, they focus on the patient. So that is what we have been really focusing on. So we have built the technology around enabling ease of access to these doctors, and ease of access to the health workers also, right? So health workers can actually get onboarded onto a platform within less than half an hour, right? I mean, that's how quickly can they can do. Now in this entire model, what you can see is, um, the health worker is actually connecting from their device with the doctor, right? So all that they do is, for patient registration, is they just take their patient details, like their name and mobile number, and that unique mobile number can actually help the patients to retrieve their medical records as well, right? So what we have built is, we have built a doctor app, and there is a patient app as well. So using the doctor app, both the health worker and the doctor can manage the entire consultation. And during the registration, whatever the phone number is given as part of the registration, patients can use the same phone number to log in to the patient app and access all their medical records, right? The aim is obviously provide them access to these digital records as and when they require. So that is also possible if they don't have a smartphone. Obviously, the health worker can provide them all the required documents, but if they have a smartphone, they can also use the app to connect or probably access some of these records. And just to highlight, specifically in India, obviously we are part of something called uh, Ayushman Bharat Digital Mission, which basically means uh, we are accredited by the National Health Authority of India. And part of our model, we can also create health IDs for every patient who's coming into our clinic, right? So today, we are some of the very few partners of National Health Authority of India, where we can create health IDs for every rural patient, and whatever medical records we generate through our platform can be linked to their health IDs. So the idea is, with that provision, we are helping them also get the benefits from the government schemes, right? So end of the day, government needs these medical records, and the initiatives is around bringing in the digital access, and bringing in the concept of digital health records for everyone in the country. So we are also participating in that equation, and as I said, our platform can enable that digital health record access to the communities as well, right? Now, moving on. Now, as we see that all this is digitally accessible, and as a doctor or as a health center, we can also examine the kind of patients who are coming in. We can examine the kind of health needs which are required on the ground, right? So there's a complete mechanism, or whatever data we are gathering in the form of medical records and patient demographics, right? All that data can be basically tracked, and this will also help us in understanding what kind of common health issues are there prevalent in that region, and what other precautionary measures can be taken to ensure that those some of those disease areas can be proactively addressed, right? So because digital is the future, and I think we are also trying a bit of ensuring that the data is accessible, where you can use this data for better interventions. End of the day, also support the government and provide agencies who are working in this particular sector with some insights on what kind of issues are prevalent in these regions, and thereby bring in some proactive solutions, right? So that is what we also do as part of the model. And I think with that, I've come to the end of presentation. I think if I've moved very quickly and very fast, uh, I can go back to any specific slide if you are interested to understand more. And yeah, now I'm happy to take any questions you have.
All right, thank you so much for that very informative presentation. Now it's time to open the floor for questions from our audience. So please feel free to type your questions in Q&A box and chat box, though I already see some question here. But before we proceed to the question and answer, I just have few announcement. So for those who are currently not a member of International Trade Council, we can offer free membership for attending this educational session. Also, you will be receiving certificate of participation. It will be sent via email in the next 24 to 48 hours. And our webinar for today is recorded and it will be uploaded to our YouTube channel. So if you would like to review, just please feel free to subscribe to the YouTube channel. So yes, the first question here, in terms of payment methods in rural areas, do the patients pay in cash, actual cash, or EFT? How is cash managed, and how does the doctor get his remuneration for this service?
Yeah. So in India, I think we have digital payment systems as well, but we can also most of them are comfortable in paying in cash, so we can collect cash. And with the senior doctors, the model is on consulting basis, right? So it is not that we are going to onboard them on a, I would say, full time basis. It's purely on the time and the number of consultations they can provide to us on a weekly basis or a monthly basis. And we they can track all the appointments from their side if they want to, or we can also provide them reports on a monthly basis on how many consultations they've done. And we have negotiated with them on the price of the consultation, because again, as I said, we are targeting marginalized communities. So some of them were very generous of enabling or providing the consultation at a very marginal prices. So thereby we consolidate that on month basis, or I would say bi-weekly or weekly, whichever pattern they like. We offer them that payment. So on at the ground, we manage the cash or either through digital payments, whichever way we take the we collect the money. And obviously for doctors, they can track on the number of consultations they do. Thereby they also know how much payment is pending on their side.
Thank you. Any more questions? Okay, here you go. Which doctors does the organization work with? Doctors working in the public hospitals, state-owned hospitals, or just any doctor from private hospitals?
So right now, we are collaborating mostly with the private hospitals, right? And uh, we are also approaching some of the government entities, but right now our model is more flexible, and it can work with any doctors. But right now our focus is mostly the private hospitals, which is also finding a value add in our model, because they are also being able to get patient inquiries through our platform, right? So in a way, it's a win-win situation for them. So right now, mostly it is private hospitals or clinics with whom we are operating.
Any more questions? Please feel free to type in your questions on the Q&A box or the chat box. All right. While we are waiting for questions, Chandra, if you have some other information you would like to share, just please feel free to do so.
Yeah. So I think I would like all of you to follow our page. Recently, we'll be inaugurating our new clinic in a temple, right? I mean, this could be a very unique information. What we have decided is we have collaborated with again a hospital in that locality and with another foundation, and we'll be starting a clinic inside a temple. So this temple is very well known in a state called Kerala in India. It's a, I would say, a very tourist and a religious destination. It's quite a big and massive temple, and so a lot of people obviously come every day, and during festivals, it is generally filled with a lot of people. So we are starting our clinic there in that temple, inside a temple. So we feel that even temples can actually enable this healthcare through their support, and this will be a first of a kind which we will be initiating here in India. So I would like you guys to kind of follow us, and as we post more details about how it is, how the entire concept is working out in this temples.
Thank you. I see one question here. How about rural locations where we have limited internet or the required speed is not available, particularly for video calls?
Yeah. So, see, I think that this is something we have taken a lot of, I would say, attention when we are building this model. Uh, Definitely, yes. So, what we have tried to do is wherever there is a bandwidth issues, if a video call cannot happen, again, in the app itself, there is a facility wherein you can enable the video or disable the video, or just do a video audio call just like the way we are doing today, right? Or probably see the patient for a few quick seconds and then continue to do a audio call, right? So there are different mechanisms we have built in inside the technology app itself, where it also takes a very very less bandwidth, as long as if the WhatsApp is working, this also will work. And coming to the internet, I think in India specifically, if you see, I think it's widely penetrated in India, because as it is, the entire nation is going on the digital transformation. So as you know, we built our payment gateways where people can pay with the phones, right? So the digital penetration is quite good, comparatively, before last 10 years. I think majority of regions are well connected, but again, if they are not connected, we can ideally find a hotspot where there is good internet access, because this model end of the day is very flexible, right? So you can actually put it there where actually the internet access is there. So I think that way it is quite flexible, and so as of now we don't have any challenges with the internet, if I have to say.
Thank you. Another question here. I'm not sure if this has been covered, but how is the patient data managed? I am asking on the aspect of regular patients, example, patients with chronic conditions.
So as you saw, every patient is obviously their digital record is created, or I would say their and that every appointment detail is created, where we have details of their gender, their name, their existing symptoms, some of their medical records, their consultation with the specialist doctor, right? So all this data is available in the system. So and we know who are the most active and prominent specialist doctors who are very active. So we'll be able to filter that specific patients who have gone to the specialist doctors, access their data, and then whenever the follow-up is given for that particular patient, so We also proactively reach out to those patients and ensure that they come back to the clinic or we go to them, right? So I think the digitization of the data end of the day is what really helping us to not only monitor but also proactively reach out to those patients who needs these special care, right? So yeah, to answer your question, so as because the data is available, we can track the patients and set reminders for them.
Thank you. One question here. In this model for patients' convenience, do you only assess patients on weekdays or also on weekends?
So right now the clinic is most of the clinics are operational from Monday to Saturday. So Sundays obviously it's closed, but yeah, Monday to Saturday is where we operate these clinics.
Thank you.
And
So,
again, yeah.
go ahead. Sorry.
No, no, I think yeah, it's it's all about the need, right? So if the need is uh, like for example, in the temple where we are starting, uh, the clinic is going to become operational from morning 8 a.m. till evening 8 p.m., right? Because that is the number of patients we are expecting a day. I mean, it could be hundreds of patients who will walk in. Temple again, it's a model where we are working on a CSR model where uh, corporate social responsibility through corporates. We are investing in those clinics and where we offer free of cost services inside the temples, right? So that is one model where we work with the corporates and through CSR contributions we can enable them. The other is the revenue generating model, which again doesn't charge very high fees on the patients, but still provide that quality services. Coming back to your question on the timings, yeah, it all depends on the kind of need. If the number of patients, volume of patients are very high, then yeah, you can operate for several days, or probably every day, or maybe alternate day, whichever the model works.
All right, thank you. I don't see any more questions here. So before we conclude our educational session for today, I would like to give another time for the speaker to announce anything about their company or anything he would like to share before we conclude the webinar.
Yeah. So as I said, we are working on two different models. One is uh, the CSR model, where we are getting funds supported by corporates as part of their CSR initiatives, and the other is the revenue model. So you can see on the screen the foundation where we are running this campaign on something called Sponsor a Clinic, and which basically enables this clinic set up in a community, and we can share more details on how this is going to work, and if somebody is interested to sponsor the clinic, if there is any specific interest on the region where they want to sponsor, so all those things can be discussed. Please visit this page. If you want to know more, you can reach out to me on my email ID or the phone number which is given. It's a WhatsApp number as well, so you can reach out to me on this numbers and contact details.
All right, thank you, Chandra. But we have two more questions here, so I'll give you time to answer these two questions. So
Yeah.
the first one is I joined a bit late, so I'm not sure if this is covered. What's the expected investment to set up a clinic on an average, say like the northern India situation, provided we have place or accommodation to start with?
So if we have a place and accommodation, so again, I think the way we have built the revenue model, uh, I think the initial investment could be less than 10 lakh, and where we are expecting a monthly expense of say 1.7 lakh, including health worker, doctor, and other consumables and other expenses. And the initial investment is primarily because of the devices and the equipment we need, right? But I think it depends. Like I'm talking about the overall expense, but you already have a place. I think you can probably, and you have some of these equipments already with you, then we can kind of eliminate that and only focus on the needed equipments and devices, and then accordingly build the model. So it's pretty customizable. but I just gave you that ballpark figure. But you can, again, as I said, you can reach out to me on my email, and we can discuss further on that.
All right, thank you. Another question here. Is this models only within the country or also are you planning to reach out of other countries?
So as I said, we are already doing pilots in Kenya. We are also doing pilots in Philippines. So I think we are flexible, because at the end of the day, the technology can be taken, as you know, anywhere. So we are open to any kind of collaborations outside India also, and some of those initiatives are already started, as I said, in Kenya and Philippines.
All right, thank you. I think we can conclude the educational session now. Again, as mentioned by our speaker, please feel free to get in touch with him. And if you have any question, you can also get in touch with ITC, so we can forward you to our speaker. So thank you, everyone. Let's celebrate your active participation and insightful contribution. We trust today's webinar has been provided valuable insights. So should you have any further inquiries or require assistance, please don't hesitate to reach out, and wishing you continued success and growth in your pursuits. Have a
Yeah.
fantastic day. Thank you, Chandra,
Yeah.
for your time today.
Yeah, thank you everyone. Really appreciate your patience and time. And yeah, looking forward to connecting with you all. And thank you, Ron. Really appreciate your time as well. And have a good day,
Absolutely.
everyone.
Sure, we look forward to having the same educational session with you in the future.
Sure, sure.
Have a good
Will do.
day, guys. Bye.
Bye. Bye, everyone.